Again, hi everyone, and welcome to the Schwarzman Animal Medical Center's 10th Annual Health Conference hosted by Anne and Charles Johnson. My name is Nicole Liebman. I'm Director of the Cancer Institute, Service Head of Oncology, and Oncology Program Residency Director at AMC, and I'll be moderating tonight's event. The Anne and Charles Johnson One Health Institute supports the One Health approach to medicine, recognizing the growing connection between the health of animals, people, and the environment. This synergism advances 21st century healthcare and helps protect and save millions of lives in our present and future generations. For the past 10 years, AMC has hosted this One Health conference to bring together professionals to learn and engage with topics that affect our approaches to both human and animal medicine. This year, we will be exploring a comparative approach to cancer diagnosis and treatment. After tonight's talk, we will take questions from the audience, which can be submitted through the chat box. And as a reminder, at the end of the event, please click the link in the chat or scan the QR code to submit your form for CE credit. So for the first day of our conference, we will be discussing the comparative oncology of leukemias and myeloproliferative disorders in veterinary and human patients. I'd like to thank both of our speakers, Dr. Ellin Berman and Dr. Brooke Britton, for joining us tonight. Dr. Ellin Berman is a board-certified medical oncologist and hematologist with a clinical and research focus on new drug development in acute and chronic leukemias, including acute myelogenous leukemia and chronic myelogenous leukemia. She received her medical degree from Harvard Medical School and has been in practice for more than 20 years. As a member of the multidisciplinary leukemia disease management team, she works closely with the many individuals who make up the clinical and research programs at Memorial Sloan Kettering. We're very grateful that she's here tonight. Dr. Brooke Britton is a native New Yorker, growing up on Long Island and returning to New York City after completing her veterinary training. She obtained her veterinary degree at Cornell and completed her residency in medical oncology at the University of Pennsylvania. Dr. Britton has been in clinical practice as a board-certified diplomat of the American College of Veterinary Internal Medicine and Oncology since 2012 in New York, New Jersey, and California. The majority of those years as head of service for the Brooklyn and downtown Manhattan oncology departments of a large multi-specialty hospital network where she was active in-house officer training and clinical trials development. Dr. Britton was subsequently appointed the director of clinical development for Veritas Veterinary Partners, a nationwide network of veterinary ER and specialty hospitals where she architected and implemented clinical training and wellness initiatives within partner practices to strategically drive medical excellence and practice growth. She has lectured nationally and is a peer-reviewed author, medical editor, and medical podcaster. Dr. Britton joined the MC as a senior veterinarian in the Cancer Institute in 2023 to return to her passion for clinical practice, house officer training, and clinical research. While she provides comprehensive care for all cancer types, her particular interests lie in the treatment of hematologic malignancies, the use of small molecule inhibitor therapy and immunotherapy in veterinary cancer patients, and the multimodal treatment of metastatic cancers. Her practice philosophy is heavily quality of life centered while delivering the highest standard of oncologic care. Outside of clinical practice, Dr. Britton enjoys aerial fitness, forest bathing, travel, photography, and long strolls in New York City with her French bulldog. Thank you to both of you. We so look forward to hearing your talks tonight.
Thank you so much, Dr. Liebman. I forgot that bio was so long, so I apologize for everyone who had to listen to my life story. But I'll start talking about leukemias and myeloproliferative disorders in dogs and cats with a little comparative flavor with humans as well. It wouldn't be complete without an introduction to hematopoiesis, which is really underpinning everything that we're going to talk about this evening. And it is a lifelong process of continuous formation and turnover of blood cells to meet everyday bodily demands and respond to increased demands, such as in the setting of injury and infection. And the apex player in this is the hematopoietic stem cell, which has the ability to self-renew, and it's pluripotent, so it can differentiate into all mature blood lineages. Hematopoietic stem cells give rise to hematopoietic progenitor cells, and there's a common lymphoid progenitor and a common myeloid progenitor, which in turn give rise to B and T lymphocytes and NK cells on the lymphoid side, and non-lymphoid cells, macrophages, dendritic cells, osteoclasts, and mast cells on the myeloid side. This is not a spontaneous process, the proliferation of these cells. It requires specific growth factors that are produced in the marrow or in the peripheral tissues and then transported to the marrow. And there are early, intermediate, and late acting growth factors that come into play. The early acting will trigger these dormant primitive stem cells to begin cycling. The intermediate acting then stimulate proliferation of the hematopoietic progenitor cells, which are multipotent, and then the late acting have their most potent effects on committed progenitor cells and in the later stages of cell development. And maturation is really the terminal differentiation to erythrocytes, granulocytes, monocytes, platelets, and then their delivery into circulation. And in some cases, this final development can occur in the spleen. This is a schematic that's adapted from comparative anatomy and histology, which just shows you the relationship between the stem cells, the progenitor cells, all the different lines that they give rise to, and what they look like and how they mature as they go through this process. So we're going to be talking about the ABCs of defining these processes because it can be a little bit confusing with the nomenclature. When we refer to leukemia, that's a cancer of blood and blood-forming tissues, including bone marrow. And this evening, I'll refer to acute lymphocytic leukemia, chronic lymphocytic leukemia, and acute myeloid leukemia in our veterinary patients. Acute myeloid leukemia being exceptionally rare for us to see. Myeloproliferative disorders, which are neoplastic diseases of the bone marrow, and they are clonal disorders of hematopoietic stem cells. Myeloproliferative neoplasms, which are excessive production of differentiated bone marrow cells. So they are incompletely differentiated or defectively differentiated. And I'll briefly talk about polycythemia vera and chronic myelogenous leukemia, which are both rare in our world. The basophilic, eosinophilic leukemias and essential thrombocythemia are also in this category, but really not within the scope of our talk this evening. Other bone marrow disorders, myelodysplastic syndrome. This is sort of a pre-leukemic disorder and is a dysfunction of hematopoiesis, typically with cytopenias in 2 to 3 cell lines, and myelofibrosis. Now, myelofibrosis that is primary is quite rare in the dog and cat. In people, this is characterized by a clonal proliferation of bone marrow stromal cells, megakaryocytes, granulocytic precursors with accumulation of collagen within the marrow. And again, that's quite rare for us to see as a primary condition in our veterinary patients. In dogs in particular, myelofibrosis, if we see it, can be secondary to myeloproliferative disease, radiation damage, congenital hemolytic anemias, and in some cases it occurs idiopathically. Sometimes we see bone marrow necrosis when it's coexistent with septicemia, drug toxicity, or infectious disease such as ehrlichiosis. And typically, if we see it, it's a complex of signs that you can see, such as anemia, thrombocytopenia, organomegaly, and something called myeloid metaplasia, which is characterized by EMH in the spleen and or liver, but that is insufficient to recover those cytopenias. So those are very consistent features, albeit very rare, that we see something like that. So starting with the lymphocytic leukemias. So lymphocytic leukemias are proliferations of neoplastic lymphocytes, which originate within the bone marrow and potentially the spleen. And the cancer cells may or may not be circulating in the peripheral blood. For us on the veterinary side, one of the main challenges we have is understanding whether we have a true leukemia that's originating from within the marrow or a stage 5 so-called leukemic lymphoma. And in veterinary patients, oftentimes the leukemias are characterized by a lack of significant peripheral lymphadenopathy, although we can have mild lymphadenopathy. There's typically more greater degree of blood and bone marrow involvement, and the immunophenotypic characteristics can signify leukemia, particularly CD34 positivity on flow cytometry, for example, which is characteristic of an acute leukemic process typically. Lymphocytic leukemias are more common than myeloid leukemia or myeloproliferative neoplasms or myelodysplastic syndrome. And by far, we see chronic lymphocytic leukemias much more commonly than ALL in our patients. Large breed dogs, German Shepherds, Golden Retrievers are overrepresented, although amongst dogs with B-cell CLL, small breed dogs tend to be more affected. As with many things in our world, middle-aged to older dogs and cats are more affected, although there is a distinct form of B-cell CLL in younger English bulldogs that are a little bit younger, albeit not pediatric. And there's no sex predilection, and the etiology is mostly unknown. When we are classifying these lymphocytic leukemias in the veterinary world, we often will classify them based on cell size and maturity, as well as immunophenotype. On the human side, they'll also look at various genetic aberrations and microRNA expression. While we can measure that, it's not as typically as practical, or we may not know as much what to do with that information on the veterinary side just yet. But if we're looking at these morphologically, so in ALL or acute lymphocytic leukemia, the top photo shows us a large immature cytologic phenotype, which is more characteristic. The majority of ALLs in our world are B cells, so they're CD21 positive. But the cells are so atypical that they can't easily be distinguished from immature cells of other lineages. And so we typically need more than just cytology or a pathologist review of a CBC. We need flow cytometry, sometimes molecular genetic analysis and immunocytochemical analysis to distinguish different lineages of leukemia. And again, if we do flow cytometry and we get a CD34 positivity, an acute phenotype is implied, or an acute leukemic process is implied, but it can be either lymphoid or myeloid. So it tells you it's probably an acute leukemia, but you don't know if it's a lymphocytic or a myeloid leukemia per se. And some T-cell ALLs don't express CD34. So if they're CD34 negative, you may still be dealing with a type of leukemia, albeit that's a rare phenomenon for us. Chronic lymphocytic leukemia, you can see on the bottom slide or picture rather that we have these small lymphocytic forms. They look more mature, and 2/3 of CLLs are T-cell phenotype. We have the remaining B-cell and also atypical CLLs, which can be a combination of immunophenotypes. This is your typical CLL patient. Very happy dog, often asymptomatic, same in cats. It's a rare disease in cats. And typically when you find it, they are retroviral negative. So they're testing negative for feline immunodeficiency virus, feline leukemia virus. And about half of these animals present incidentally, half have non-specific, usually mild constitutional signs. And the most common thing we find is an incidental finding of lymphocytosis on a CBC. So it's usually the dog that goes in for the dental cleaning and gets a CBC and has a lymphocyte count of 40,000 and then gets referred to us. In more advanced cases of chronic lymphocytic leukemia, we can have lethargic, inappetent animals, or sometimes lymphadenopathy peripherally or visceral lymphadenopathy. Abdominal lymphadenopathy, cranial organomegaly. Mediastinal mass is quite rare for a chronic disease process like this, but it's been reported. And other cytopenias can be present, but they're usually fairly mild. They can also be hyperglobulинemic, particularly, as you might imagine, the B-cell patients. We can see paraneoplastic syndromes with CLL. Usually not quite as severe a presentation though, but monoclonal gammopathy, immune-mediated anemias, pure red cell aplasia, hypercalcemias are fairly rare in the CLL cases. This is contrasting with ALL. So just for orientation in this picture, the dog's head is off to the left, the vulva is lower right, and the left hind leg is being kind of opened to show you the ecchymoses on the inside of this dog's leg. And these dogs and cats are sick with ALL. It's very rare to catch it as it's emerging. Usually they're lethargic, inappetent, they're losing weight. They may have splenomegaly, often significant or massive splenomegaly. And the bone marrow infiltration tends to be extensive and the cytopenia is severe. many times with evidence of what we call myelopthesis. Myelopthesis is a process whereby the bone marrow gets effaced or completely taken up with the neoplastic cells. So it crowds out the normal bone marrow cells, and you can see significant and catastrophic cytopenias. We can infiltrate extramedullary sites like the CNS, the bone, the GI tract. Interestingly, with ALL, the majority of cats are actually feline leukemia positive, and most are of the T cell phenotype, but the phenotype for us in this disease doesn't matter quite as much because the disease is uniformly aggressive and unfortunately fatal. It's also important to keep in mind what is normal, right, for circulating lymphocytes in dogs, and we assume in cats as well. So around 80% of circulating lymphocytes in dogs are T cells, and around 15% are B cells, the remaining NK or double negative T cells. So if we see that there's a huge proliferation of lymphocytes with a B cell phenotype, for example, or if we see that the lymphocytes are very bizarre and atypical looking in circulation, or if we document clonality, for example, which we can do with PAR analysis, which is a DNA test. It's PCR for antigen receptor rearrangements. That's what PAR stands for. And we're looking for specific genetic rearrangements in the T cell receptor gene or the immunoglobulin gene. Other differential diagnosis that we can have with lymphocytosis, we can see it with infectious disease, retroviral disease, endocrine disease, sometimes post-vaccinal lymphocytosis in dogs and cats. But you can see that even though these lymphocyte counts are elevated, they're not markedly elevated like they may become in both CLL and ALL. How do we work these patients up? We typically do a minimum database, so CBC, chem panel, urinalysis, and we always want to stage with thoracic and abdominal imaging, even if lymphocytosis is the only finding in an otherwise well-appearing animal. I should say only initial findings. So we go hunting for disease in other areas of the body. Usually we are doing flow cytometry as well to better characterize the lymphocytosis and presumed leukemia. We can either do flow on the peripheral blood or on a bone marrow sample. At AMC, we tend to send our samples to Colorado State. We find that they have an excellent turnaround. They have very thorough reports, but flow cytometry can be done in other labs as well around the country. And bone marrow aspiration, particularly in cats who don't like to throw their leukemic cells into circulation as much as dogs do. In CLL, we'll find that typically greater than 30% of nucleated cells will be comprised of these neoplastic lymphocytes, but in ALL, they predominate, they take over, and other lineages are typically significantly decreased. When we talk about treatment and prognosis of CLL, it's really to treat or not to treat. Many of these patients we will actively surveil. If the lymphocyte count is under 50 to 60,000 and they're otherwise clinically well with no significant cytopenias, the indications for treatment are more an increased lymphocyte count above 50 to 60,000, or if they're rapidly increasing, if they have constitutional signs, or if they demonstrate significant lymphadenopathy or organomegaly. And usually, although this is not a lecture about how to treat leukemias and these disorders, usually we're using a steroid like prednisone or prednisolone in the case of cats, and a slow alkylator like chlorambucil in dogs and cats alike. If we have significantly elevated, markedly elevated cell counts or a massive spleen, et cetera, we may look at using injectable chemo, maybe adding vincristine to chlorambucil, switching to cyclophosphamide, or using a combination of those drugs for more severe or refractory cases. Leukemias and all of these conditions that we'll talk about really are incurable for the most part. Therapy is typically long-term or lifelong. High response rates initially with CLL, and normalization of lymphocyte counts in about half to 3/4 of cats and dogs with the disease, and survival times of 1 to 3 years. There's some phenotypic differences in survival, we think, in cases of CLL, but not in ALL. And young age and anemia are negatively prognostic in dogs. We also have a phenomenon of malignant transformation that these animals can undergo, and about 10% or less of dogs in particular. It's not as well characterized in cats because it's rare, but it's something called Richter syndrome, which can happen in people. In our world, we call it Richter-like acute disease, where they can become very sick all of a sudden. And it can happen at variable time points after their diagnosis of CLL, but the median survival time after a Richter's-like transformation is unfortunately very short. It's under 2 months. So these are refractory patients. With ALL, again, unfortunately, these patients are very sick and the prognosis is typically poor to grave, days to weeks to months. We support them the best we can with transfusion of blood products, broad spectrum antibiotics, because they're typically very myelosuppressed or have myelophysis, nutritional and fluid support, and monitoring for sequela of their disease, sepsis, hemorrhage, DIC. We throw everything that we have at them in the book in terms of chemotherapy and steroid because there's no established standard of care. In humans, they do bone marrow ablative treatment, or they have the ability to do that with stem cell or marrow replacement. Unfortunately, not as accessible in our world at this point. And so these animals invariably. For acute myeloid leukemia and the myeloproliferative disorders, these are much less frequent than the lymphoproliferative disorders. And we'll talk about a couple. One is AML, or acute myeloid leukemia, which implies uncontrolled proliferation or decreased apoptosis of cells that cannot mature. So they're incapable of maturation, they stay as blasts, and then they accumulate in the body and the marrow. Myeloproliferative neoplasms are accumulation of cells with incomplete or defective maturation. So they try to become adult cells, but they don't do it very well, and they can become an MPN as a result. No consistent breed predilection, though mostly large breed dogs with the same median age as our lymphoid disorders, and there's a 2-to-1 male to female ratio for AML. In dogs and cats, the etiology largely unknown, although in people, we can see acquired chromosomal derangements that lead to clonal overgrowth and arrested development. We have reported chromosomal abnormalities in dogs with AML and CML. It's difficult to karyotype dogs and characterize these diseases because they have so many chromosomes and morphologically they're so similar. So it's very difficult for us to do. In terms of classification, I'm going to talk just a little bit about classification because it doesn't really behoove us at this point in time, and others may disagree with me, probably those in academia on the veterinary side who are spearheading this work, but on the clinic floor, classifying these leukemias, we don't really know how to treat them differently at this point in time. So this animal leukemia study group, which is a working group of clinical pathologists, developed an adapted classification system based on the human and according to a bunch of different criteria: biologic behavior, cellular differentiation, etc. In humans, of course, they have very sophisticated classification systems using genetic and molecular analysis. We are catching up, as is the case with many things on our end, but we have identified and classified all AML subtypes in dogs, with the exception of M3, which is the fourth one down on the left, promyelocytic leukemia. This classification scheme is not meant to be memorized or even in your head any more than this slide, but it just goes to show you how many different types of acute myeloid and chronic myeloid and dysplastic syndromes have been classified. But again, in the dog and even less known about the cat, we just don't know how to treat them differently. So you often will not hear us, even at an institution like the AMC, talking about these classifications because we don't know what they mean yet in our world. This is a picture of a cat with hypopyon in the right eye. This can happen amongst many other symptoms and clinical signs with acute leukemias. AML is rapid onset, it's progressive. They have constitutional signs, typically fevers. They have lymph node enlargement and organomegaly. Peripheral lymphadenopathy, more common in dogs. And again, they tend to have pretty significant cytopenias. The white blood cell count, interestingly, can be variable, can be leukopenic. They can have hundreds of thousands of white blood cells in their marrow and on their CBCs. And occasionally, especially cats, they're subleukemic or aleukemic. So you don't know truly unless you go hunting in the marrow. And myelophthisis is more common in these patients. Pardon the slightly unprofessional frown face, but as with acute lymphoid leukemias, the myeloid leukemias are even worse, typically days to weeks prognosis in our world. We identify them through bone marrow aspiration and flow cytometry in much the same way. I've listed some other markers to identify AML under the flow cytometry bullet point, which pathologists can help you with if we're confused about what type of leukemia we're dealing with. But unfortunately, if we have a clinical suspicion or confirmation of this type of leukemia, for our patients, there's no accepted standard of care, though we will try chemotherapy steroid, and the prognosis is pretty dire. Moving right along, the myeloproliferative neoplasms. So again, these are differentiation disorders. So the most common one that we'll probably see, which is yet rare in our world, is polycythemia vera. This is a neoplastic proliferation of the erythroid series with terminal differentiation to red blood cells. Middle-aged dogs more predisposed, no sex or breed predilection. And we see this markedly increased PCVs, typically 65 to 85%. Unlike in humans, other cell lines are typically uninvolved. So this may be the only thing that we see. And it does not typically result in transformation to other myeloproliferative disorders in our world. In humans, the vast majority have acquired genetic mutations in JAK2. And interestingly enough for us, right now we use phlebotomy. We remove a lot of blood volume with colloid or crystalloid replacement. We give them chemotherapy, hydroxyurea, which is an oral medication, which can cause nail sloughing. That's one of the potential side effects in bone marrow suppression. But we do have JAK inhibitors. We have drug Apoquel in dogs. We haven't studied it for this purpose, but in people, they use a JAK2 inhibitor as well as phlebotomy and other treatments. So potentially something that we could explore in our world. And the prognosis can be fairly good, although not something that we typically reverse or cure with our treatments. CML, chronic myelogenous leukemia, is rare for us. It's more similar in dogs to chronic neutrophilic leukemia in people. It's in our world a neoplastic proliferation of the neutrophil series predominantly. You can see eosinophilic and basophilic differentiation as well. Any age, sex, or breed, and these cell counts are typically hundreds of thousands. Both mature and immature forms are present. I've seen a couple in my life. The most recent was a tiny little Yorkshire Terrier who felt good with a 400 to 500,000 white blood cell count for a little while. We can see other cell lines affected as well. And we have to distinguish these from what are called leukemoid reactions. So that's an extreme neutrophilic leukocytosis caused by inflammation, immune-mediated disease, or as a paraneoplastic syndrome. In people, they actually possess a chromosomal translocation between chromosomes 9 and 22, called the BCR-ABL translocation or the Philadelphia chromosome. And the analogous chromosomes in dogs are chromosome 9 and 26, and we call it the Raleigh chromosome, but it's a similar translocation. So we can identify it, although it's difficult for us to do that in a practical way in a setting like clinical practice outside of academia. We can find leukemic cells in other organs as well as lymph nodes, kidneys, heart, lungs, so they can live in other areas of the body. In people, there are well-documented treatments, including drugs like imatinib, which is a small molecule inhibitor. On our side, we have the veterinary toceranib phosphate, which is Palladia, as I'm sure all of you know, with prednisone, as well as hydroxyurea in the chronic phase. And we can use multi-agent injectable chemotherapy for dogs that go into blast crisis, which is typically where we have a transformation to poorly differentiated blast cells in the blood and bone marrow. And you can imagine, as the name implies, that a blast crisis is not a very good thing. And they don't live very long after they transform. But we can maintain them when it's in the chronic phase for up to a year or more on therapy. And typically, death occurs to complications from infection due to neutrophil dysfunction or hemorrhage secondary to thrombocytopenia. Almost done on the veterinary side. We also have myelodysplastic syndrome. So that's a dysfunction of the hematopoietic system in general. Typically, we see cytopenias in 2 to 3 cell lines in the peripheral blood. The bone marrow itself, if you do bone marrow cytology, is normally normocellular to hypercellular, and the cell lines are just dysplastic, and the blast cells should be low, right? So we call this often a pre-leukemia. It's not quite there yet, but we're concerned that at some point it's going to get there. And that kind of latent period for development to leukemia is variable, but we can infer that a patient's going to do better or worse by certain prognostic factors, including increased percentage of blast cells, cytopenias of more than one cell lineage, and cellular atypia. Those are poor prognostic factors in our world. Again, as with many things in the human world, the classification schemes are much more complex. They look at blast percentage, cytogenetic analysis, the need for transfusion. There are at least 9 subtypes of myelodysplastic syndromes, but its relevance in veterinary medicine is unknown to us. We don't know if we did subclassify MDS this way, if it would make a difference in terms of how we treat or how these patients do. But we do have 3 that are proposed for dogs. MDS of excessive blasts, where we see progression to AML being more possible. MDS of refractory cytopenias, where we have cytopenias of 1 or more lineages with a blast percentage that's low, under 5%. And MDS of erythroid predominance, where we have a myeloid to erythroid ratio less than 1, and that happens to have quite a poor prognosis. We can technically reverse MDS if they're secondary to immune-mediated or infectious causes that we otherwise treat in dogs and cats. And treatment, again, no standard treatment. In humans, if they're aclinical, patients are monitored. If their cytopenias are fairly mild, they get transfusions if warranted, treated for infection. If they have a fever, they can administer growth factors and differentiation agents. For us, we have the same things at our disposal. But again, it's very difficult to predict exactly how these patients are going to progress. And when they do, they don't tend to do very well when they actually transform to a leukemia. So there's a lot that we don't know on our end of things, but we do the best that we can. So very complex, kind of complex and somewhat confusing classifications, but hopefully that made it a little bit more clear. And I'll take questions at the end. I'll allow Dr. Berman to speak, and I'll turn it over to her.
Unmute. Oh, there we go. Perfect.
Okay. Thanks. Well, first of all, thank you very much for inviting me to this seminar. I really appreciate it. And Brooke, your discussion was really very broad ranging. And I'm going to quote a former presidential candidate by saying, I think that we have more in common than we do have differences among us or between the leukemia subtypes. There's a remarkable similarity, and then some areas where there's been more in-depth, not discovery, but more of a description of these diseases that remain to most of us still a mystery and still unsolvable, and in many instances incurable. we have one option that the veterinary world hasn't explored yet, and that is bone marrow transplant. So for many of our patients for whom treatment is unsatisfactory, we can offer bone marrow transplant. So I'm not going to repeat a lot of what Brooke said, but just bring in some of the differences between the human world and the canine and feline world. Can I have my next slide, please? So we're just going to talk this evening about AML, which is the most common, unlike in dogs and cats, it's the most common form of leukemia in adults. Median age is 65. It ranges from, we see some of the pediatric patients as they get older and age out of the pediatric group, but mostly adults. ALL median age is in children around 7 or 8 years old. But we do see it in adults, and it tends to be a much more refractory disease to chemotherapy. And then just to concentrate on what we see as probably the most common myeloproliferative disorder, which is CML. So if I can have the next slide. A typical human slide of blast looks very similar to a canine slide, and we see prominent nucleoli and very disorganized nucleoli, and those connected dots that we see are actually called our rods, and those are just myeloid particles that line up in a line, and that's confirmatory of AML. And the next slide. These are more some of the myeloid blast. And you can see how unwound the nuclear chromatin is, where all of this DNA, abnormal DNA is being made. And next slide. AML, as I mentioned, median age, older adults, and there are factors that contribute to incidence of AML, which include Down syndrome, Fanconi's anemia, and Wiskott-Aldrich syndrome, all of which are relatively rare in the adult world. They're more commonly seen in children. But the exposure history in adults is really very interesting. And I just listed some of the known exposures, which are toxic solvents like benzene, pesticides, and then prior chemotherapy. So we see AML commonly in women who've survived breast cancer treatment, chemotherapy, men who've had radiation for prostate disease, so prostate cancer. So the other thing is, if you ask, you will find out more information. So we try and teach our fellows and our residents to go into detail about what exposure histories actually are. So for example, where I grew up, and I use this as an example, we used to have our feet radiated every September before buying shoes in the shoe store. The shoe store had a fluoroscopy machine, and it could actually x-ray your feet, and then the shoe salesperson could tell your mother when your next pair of shoes were due. So things like that. We also ran behind the pesticide truck on a hot summer day. No one told us anything differently. And we were sprayed with pesticides, which were cool. And if you didn't have a place to go swimming, you could get your bath with the pesticides. So if you ask, you'll be surprised. Also, we see people, immigrants from Russia who were part of the Chernobyl disaster or lived 100 or 200 and 300 miles south of where the actually the toxic cloud was. And when you see where the cloud from Chernobyl went, it turned right and then turned left and went directly south. And this particular patient that I'm thinking of lived in Odessa and worked. And when we inquired what his role, what he did, and whether he was exposed, he was. One particular patient stands out who took children, heavily irradiated children in the wave of the Chernobyl accident, and actually lifted them from the trucks that brought the kids to the one functioning hospital 300 miles away, and actually carried them into the hospital. So he was directly irradiated by working with children who were directly irradiated. So I think it's always important from a human point of view to find out how people actually lived and what they had as childhood exposure and perhaps even as adults. So I can have the next slide. The leukemia field has rapidly expanded in the last, I'd like to say 10 or 12 years. And we used to, as Brooke mentioned, the French, American, British, the FAB category in adults has now shifted largely to molecular and cytogenetic abnormalities. So in the most recent edition of the WHO from 2 years ago, we no longer use morphology, which is how many of us were brought up with to how we categorize leukemia. And now we use a strictly molecular approach to understanding the disease, because in some instances, such as the NPM1 leukemias, we've actually been able to develop drugs that can actually shift the mutation. That's, however, only a small percentage of leukemia subtypes for which we have treatment. And in the most of the time, we still use the chemotherapy combination. And if I can have the next slide, that we used as interns, which was in the previous century, actually, which is a combination of cytarabine and daunorubicin or idarubicin, the latter being an anthracycline. And there have been many ways we have looked at this over the years, but treatment has not changed. We still use the combination that's been 40 years in humans. This disease still has a survival rate, with one exception, molecular subtype that Brooke, you actually mentioned, called acute promyelocytic leukemia, which is the FAB-M3, that has a cure rate of close to 90%. The remainder of the AMLs have a very dismal prognosis, despite using different anthracyclines or different doses of cytarabine and even daunorubicin. That's usually the cytarabine and daunorubicin is usually used for people under the age of 65, and for people older than that, there really has been a slight incremental increase in overall survival with a combination of azacitidine and venetoclax. This was piloted by the group at MD Anderson, I want to say 10 years ago, and this really has shifted the very dismal prognosis of adults over the age of 65, where now a significant percentage of people, about 60% of people, 70%, can actually achieve a morphologic and sometimes even cytogenetic remission and go on to a stem cell transplant. The stem cell transplants in the past have been limited to the age group less than 60. And at Sloan Kettering, we've advanced that and actually have transplanted people in the age group of 70 with surprisingly good overall survival. So we have now begun to shift thinking, at least our thinking about the standard cytarabine and daunorubicin approach, to even using azacitidine and venetoclax in a younger population. And as I mentioned, in patients with the APL subtype, they have an excellent survival with high-dose vitamin A, which is something that the Chinese physicians first brought to our attention with all-trans retinoic acid. But now we combine it with chemotherapy, and we consider the majority of patients with APL, but this subtype only, to have a high chance of cure without a transplant. And if I can have the next slide. And this slide here shows the importance of transplant. The high curve that's light green on this not well seen slide shows the overall survival, which approaches 60% in patients who are eligible for transplant, compared to all of the other patients who've gotten chemotherapy, whether it's high-dose chemotherapy or even standard venetoclax in combination with azacitidine. While the latter group has a longer survival, ultimately everyone succumbs to their disease unless there is a transplant eligibility. And the next slide. So we'll shift now to acute lymphoblastic leukemia, very similar morphologic picture in as that's seen in dogs. And this slide over on the far right is a slide of a Burkitt's lymphoma, which is a form of acute lymphoblastic leukemia, typically younger men with a mediastinal mass, a very aggressive disease, but also highly curative with ALL type therapy. So these cells usually have a more dense chromatin pattern and a smaller cytoplasmic component to them. And if I can have the next slide. The ALL patients likewise have undergone a very detailed, descriptive analogy to AML, but with a different chromosomal or different molecular approach. And this is more of our current classification that again is based on cytogenetic abnormalities or molecular abnormalities. In particular, most of these cells, unlike while most circulating cells in adults are T cells, much like they are in animals and dogs, the leukemia that is more common in adults is a B lymphoblast type picture, including the T922 translocation lymphoid blast crisis of lymphoid blast crisis of CML. And if I can have the next slide, please. The features of ALL are very distinct. Unlike AML, which almost all patients, except for those patients with the good genetic subtype, almost all patients with ALL can be divided into good prognosis and poor prognosis. And good prognosis includes a younger age, a lower white count, and a rapid response to chemotherapy, which makes intuitive sense. And something that I haven't quite had thinking about, I can't understand why children, especially those who have hyperdiploidy, have a good prognosis. And those children who have the 1221 translocation have a very good prognosis. But only while the cure rates in childhood pediatric ALL approach 80% and higher in specific subgroups, especially those children who have a prompt response to treatment, only about 30% of adults with ALL can be cured. So really emphasizing the difference between ALL in children and ALL in adults, in part because of the multiplicity of chromosomal and mutational abnormalities that are seen in adults. Criteria for poor prognosis: older age, high white count, slower time to achieve remission, what's called a precursor B cells that's more than 100,000 per milliliter, and the presence of specifically two chromosomal abnormalities, the Philadelphia chromosome, the 922 chromosomal abnormalities, and this particular 411 translocation, which is also tends to be resistant to treatment. And the next slide. To just touch briefly upon the myeloproliferative disorders, there are remarkable similarities between polycythemia vera in adults and in dogs and cats. We also do phlebotomy. We also use hydroxyurea. So there are really basically no differences there. Essential thrombocytosis, very challenging disease to treat. Again, we use hydroxyurea here. For myelofibrosis, where the cell of origin is the bone marrow fibroblast, another very challenging disease to treat with no curative approach apart from a bone marrow transplant. And then the disease that really has had the biggest turnaround, the real home run in all of the leukemia research, I want to say in the last 30 to 40 years that I've been studying the disease is chronic myelogenous leukemia, which of course involves all cell lines. And if I can have the next slide. Here is a slide of the 922 chromosome in adults. There's actually chromosome 11 involved in this slide. I didn't realize it until I had already made it into a slide. But the standard 922 translocation is a reciprocal translocation. Actually, a piece of 9 goes to 22 and a piece of 22 goes to 9. But the hallmark, what Janet Rowley first described in the 1950s, was this abnormal chromosome 22, or the Philadelphia chromosome. And I just had to ask Brooke, the so-called, because it was first discovered in Philadelphia, I'm assuming this was Raleigh, North Carolina, where the animal, the canine Philadelphia chromosome equivalent was found. And that has really been the treatment for this has been transformative, if I can have the next slide, with the introduction of the tyrosine kinase inhibitors. So in adults, CML has typically 3 phases, or had typically 3 phases. We rarely see accelerated and blastic phase. Most adults are, and this is a disease of adults, most adults are diagnosed in chronic phase disease, and the determination is based on the percentage of bone marrow blasts. And prior to 2001, when imatinib or Gleevec was first brought out, the survival was about 4 years unless you were able to identify a donor and undergo a stem cell transplant. And now the survival is remarkable. It's 90% of adults that are alive at 10 years. And this was because of the discovery of the tyrosine kinase inhibitor imatinib, which physically blocks the 922 translocation from producing its toxic products. And we now have additional drugs. We have 5 first-line therapies to use: imatinib or Gleevec, then dasatinib, which was licensed in 2007, nilotinib in 2008, bosutinib in 2012, and asciminib just last week. And just as a heads up, asciminib looks like it's going to be the home run of all of these drugs. It works the most quickly, and it has probably the least amount of toxicities. And so we are now able to use this drug in first-line therapy. And this has really changed dramatically the whole treatment of CML. And that's really the remarkable story of adult leukemia. And if I can have the next slide. Yeah, so just a very brief, I just wanted to make sure that we brought this under 8 o'clock, and we have some time for questions. So this is the best picture I could find of a dog with a lot of questions, like when's dinner? So more than happy to answer with Brooke any questions you may have. Again, the similarities are really remarkable. And the focus, if I had to summarize adults from the murine and canine and murine, is that the focus has been really on dissecting the chromosomal abnormalities. We haven't found the solutions, with one exception, but the in-depth look at the chromosomal abnormalities has really revealed how complex and how that AML title actually encompasses many different diseases, which wouldn't surprise me. It doesn't surprise me because of its refractory nature to treatment, but also is what you may be dealing with in dogs, where there's such a short survival time because the treatment just doesn't work.
Well, we have some questions here
I see that.
in the chat. One of them is, I recently heard about some veterinary medical oncologists that do bone marrow transplants, something I heard about being performed. Why is that? Do we have enough evidence-based info in vet med to recommend them, or technical difficulties, or both? That would be for Dr. Britton.
Sure. Thank you for your question. I think that is the direction that we would all love to go in. Unfortunately, accessibility is an issue for us in our world. There aren't a lot of people doing transplantation, and we don't quite have the wealth of data that's published in our world is on the human side to know exactly what we get with transplantation. We have other barriers in terms of quality control, cost, again, limited accessibility, and the wait lists for transplantation in the places that are doing them are just so long that unfortunately we often don't get our patients in, even for very motivated clients that want to go the extra mile for their animals in a reasonable time frame to be able to treat their disease.
I might also just add that the toxicity of a transplant is not light, and in humans, you can explain it not particularly well to children, but for adults, it's a very miserable, or can be a very miserable 4 to 6 weeks. And for animals, it might be harder to watch just because they might not understand the sore mouth, the diarrhea, the abdominal pain that the humans experience, but the humans can at least be walked through it. But it's not yet an easy procedure for most adults, I would say.
It's very true. North Carolina State had a really robust bone marrow transplantation program and was training fellows, and it's recently been dismantled, I think, because of funding and other concerns with staffing, et cetera. But those dogs really went through the paces. They were typically transplanting lymphoma patients, preferentially B-cell lymphoma patients, although they did transplant some T cells. And those dogs went through the paces. They were in the hospital for, on average a week, and they get myeloablative doses of chemotherapy. So they get very sick. They're very vulnerable. They did have long-term survivors, but they didn't publish, a treasure trove of data. And again, for accessibility issues, we just don't have the data or the accessibility, although it's, as in people, because the dog disease is so analogous to the human in so many ways. If we had it available, we probably would be doing it. But there are a lot more considerations in our world. We don't have consent from our patients. It's extremely costly. People have to fly their dogs all over the country to get it done. And there's a very specific subset of people that are also willing to do that for their animals.
I totally get that. We have adults who say this is not something that they want to go through, and that's with an informed consent. So I understand pet owners being one myself, but I might have a lot of thought about going for a transplant for my dearly beloved dog. Yeah.
Okay, thanks. I'm going to jump to another question now. Where does MIGS or monoclonal gammopathy of unknown significance and multiple myeloma fit into this picture? Dr. Berman, do you want to answer that
Yeah,
one?
so just a question for Brooke. Do you see plasma cell disorders frequently in dogs and cats?
Yes, we do. Yeah.
So we see it, MGUS more, I think, now than we've ever seen before, in part because people are getting very broad testing when they see their doctor. They may get a set of immunoglobulins, which is not, we consider necessarily something that we get when we see our general medical doctors. So MGUS does fit in, and fortunately we are able to monitor many people, and only a fraction of those people go on to develop multiple myeloma. So myeloma still remains a largely incurable disease. There are newer myeloma programs, including stem cell transplants and allogeneic brother-sister transplants, sibling transplants, but it remains a very challenging disease that is only cured by transplants. So again, many of the adult diseases for cure go on to must include a transplant if we're talking cure.
Okay, I have a question actually. Dr. Berman, you talked about second malignancies. AML is a second malignancy in women who've been treated for breast cancer or men who've been treated for prostate cancer. And I was wondering the time frame, is it decades? How long is it until, these second malignancies rear their ugly heads?
So that's a great question, and it really depends on the chemotherapy that's been used. So for example, women and the few men who've been treated with breast cancer have a much shorter interval. We're talking 3 to 4 years, in part because we use anthracyclines a lot in frontline therapy. And the interesting protocol that we're looking at, the leukemia doctors are looking at, is a one that's recently being come into play, and for women who have a metastatic breast cancer at time of diagnosis, because the breast cancer investigators are using immunotherapy in combination with chemotherapy. So the answer is breast cancer, short interval; ovarian cancer, where alkylating agents are used, much longer interval. Men with prostate cancer, depends if they get chemotherapy and radiation or radiation therapy alone. So it really depends on the underlying malignancy.
And in children too, do we see children that are treated for leukemias who actually develop additional?
They do. They develop them in adolescence. So we see the adolescent, depending upon the age at our hospital, we'll see 18 and 20-year-olds, whereas the 14 and 15-year-old the children, young adults who have second leukemias are usually cared for by the pediatric team. But those secondary leukemias tend to have multiple chromosomal abnormalities and tend to be very challenging to treat. Yeah, sadly.
I think we have time for one more question. What is the role of immunotherapy? Is immunotherapy treatment an option for human and veterinary patients?
Brooke, are you using CAR T cells, or are you using any immunotherapy type, or has that been moved over into to your world?
We have some clinicians that are looking at CAR T cell therapy, and it exists in our world, but we don't have, again, a wealth of data for it to be widely used, or to be able to manage expectations for what we get with it. But it does exist and being actively researched. We don't tend to incorporate too much immunotherapy at this point in time for these diseases, but it's out there.
So just as a quick descriptor, CAR T cells are really a very innovative way for selected leukemias. So for example, for selected, really mostly lymphoid cancers, for example, CLL and multiple myeloma, it's the patient's lymphocytes are taken out and they are exposed to particular antigens that are present on the plasma cells in myeloma, or the ALL cells, the antigens present on the ALL cells. So these are lymphocytes that develop a killer ability, and those patients' lymphocytes are infused back into the patient, and really remarkable responses. And interestingly, it's being used in solid tumors too. So for example, it works in mesothelioma, and tumors that arise in the lining of the lung, which the blood supply is really very limited to. And we're seeing remarkable responses in tumors that we wouldn't normally expect. But it's really, at least right now, the technology is limited to leukemias and lymphomas and solid tumors, where the antigens are expressed on the surface of the cell and they're easy to form antibodies against, which is not the majority of solid tumors, and certainly not the majority of leukemias. But for those tumors that have obvious antigens, it's been a huge turnaround.
Great. I think we will wrap it up. It's after 8. I just want to thank everyone for joining us tonight. Please click the link in the chat box or scan the QR code to submit your CE credit request. Certificates of attendance will go out on Wednesday, November 20th. Dr. Berman, Dr. Britton, thank you so much. There's so many excellent and appreciative comments in the chat box. So it was a big hit, which is great. Tomorrow's topic will cover oral tumors, and we will be joined by Dr. Jay Newgarten and Dr. Jonathan Ferrari, and we hope to see you there. Have a good night.
Thanks,
Thank you
Nicole.
so much.
Thank you.